Welcome back, everyone. Thank you for being with us. So we have come to the last lecture before our break. So we are happy to have Dr. Silva with us. He will talk to us about evidence-based surgery in the infertile patient with endometriosis. So before I proceed, please allow me to briefly introduce Dr. Silva. He is the consultant obstetrician and gynecologist and a specialist in reproductive medicine at the Mahkota Medical Center in Malacca, Malaysia. He also heads the IVF center at this hospital. He is the fellow at Royal College of Obstetrician and Gynecologists. He obtained his master's in reproductive medicine from the University of Western Sydney in 2003, and he is the past president of Obstetrical and Gynecological Society of Malaysia, the past president of the Asia Pacific Association of Gynecological Endoscopy, board member of Asia Pacific Gynecological Endoscopy Group, and past board member of the International Society of Gynecological Endoscopy and a reviewer of the Journal of the Asia Pacific Association of Gynecological Endoscopy. Dr. Silva also runs a fellowship in minimally invasive surgery and infertility at Mahkota Medical Center, the first of its kind in a private hospital in Malaysia. So far, he has trained 9 gynecologists. So he also has recently published his first book entitled Laparoscopic Surgery in Gynecology and Common Diseases in Women, a book to educate the public and doctors on the benefit of laparoscopic surgery in women. Soon, he will be starting the first ultrasound-based HIFU center in Malaysia for fibroids and adenomyosis. So let's welcome Dr. Silva, and I'll pass the floor to you now, Dr. Silva.
Hello everyone, I'm Dr. Silva from Mahkota Medical Center, Malacca. Thank you for the kind introduction, and thank you to OGSM for inviting me to speak on this topic. This is not an easy topic, and my topic today is evidence-based surgery in an infertile patient with endometriosis. Now, we all see patients with endometriosis, and first of all, I have no disclosures, and I also like to acknowledge Dr. Sarah Mubarak, who has done a lot of the research on this topic and the papers that she has come up with for me's presentation. Now, we all see patients with endometriosis, and basically we see patients with endometriosis. They may be single and they may be married. And in the married group, there may be patients who are not keen to conceive, and there will be a group that's keen to conceive. And in the patients in the group that is keen to conceive, we have patients with minimal to mild endometriosis and patients with moderate to severe endometriosis. And in the group with moderate to severe endometriosis, we have patients with deep endometriosis or deep infiltrative endometriosis and patients without deep infiltrative endometriosis. So in this talk, I will be talking on this group only, the married women who are keen to conceive, and more on patients with moderate to severe endometriosis, not much on minimally invasive endometriosis. These are a big group of patients. A lot of things can be discussed here, but I'm not going to touch on this. So my area of talk is basically in this area. Now, what are the points to discuss? The first point is, when should we do surgery for endometriosis in a patient who is keen to conceive? The second point is, how should we do the surgery? So these are the things that I'm going to discuss today. Now, let's look at a common case scenario. Now, we have this 31-year-old lady who's married for 1 year and she's inability to conceive. She has menses which is of normal flow and has some dysmenorrhea, not that bad. Examination revealed a normal size uterus with nodules in both the uterosacral ligaments. Ultrasound shows a normal size uterus with bilateral endometrioma, left 3 times 4 centimeters and right 4 times 5 centimeters. This is one of the common patients that you and I see in our practice. Now, the first thing I would like to tell you all is that according to American Society of Reproductive Medicine, a patient like this with an endometrioma of 4.5 centimeters, unilateral or bilateral, will definitely be moderate to severe. Why I say this is, as you can see here, the patient is more than, the cyst is more than 3 centimeters, and there is some additions is already 20 points here already. It's already, moderate is 16 to 40 points, and severe is more than 40 points. So if you count everything with some partial cul-de-sac obstruction, this patient will be moderate to severe endometriosis. So majority of our patients whom we see in our practice are in this range, moderate to severe endometriosis. And this is where the problem comes. How do we deal with this kind of patients? Now, what are your options? Many of us will jump and do surgery. So is this the right thing to do? And there is actually other options. You can actually do IVF, freeze the embryos, and then do surgery, and then do frozen embryo transfer. You have another option, that is, you can do IVF and then do ET and FET, and no surgery at all. Only when this thing fails, then you will consider surgery. This is one other option. And in these patients, when you have done surgery, you will have this option of waiting and seeing whether a patient can conceive spontaneously. If she doesn't, then you may want to consider ART. So these are all the options, and this is what I'm going to discuss today, which is the better option for your patient. Now let's look at this paper. This paper was published in the year 2012 and it's entitled, "In Women with Endometriosis, Anti-Mullerian Hormone Levels Are Decreased Only in Those with Previous Endometrioma Surgeries." So the question asked is, if a patient has endometrioma, is her AMH already reduced even before surgery? So that's what they did. They took patients who have got endometriosis and patients who do not have endometriosis, and they measured the AMH level, and they found that the AMH level actually did not come to any significant difference. It's actually the same whether the patient have endometriosis or not. However, the AMH level is significantly decreased when the age increases. We all know that as the age goes up, the AMH will come down, and in women who have previous endometrioma surgery, irrespective of whether the patient has endometrioma when the study was done. So if the patient has an endometrioma and she had a previous surgery, her AMH level is lower. So what they concluded is that our findings suggest that endometrioma per se do not diminish the ovarian reserve reflected by the AMH levels, but the alteration is seen in women with endometriosis. The alterations seen in women with endometriosis are a deleterious consequence of endometrioma surgery. So if you do surgery, your AMH is going to come down. With this in mind, so look at this patient. What are the options? Now, if you take this patient, she is actually better off not doing surgery and straight away going to IVF and ET with fertility and see whether she gets pregnant. And that probably should be the first choice. But unfortunately, our patient, what are the things that our patients want? Our patients want to conceive naturally. She has got endometrioma, but she wants to conceive naturally, and she wants some pain relief, and she can't afford IVF. This is the group of patients that we see. If I were to tell this patient who walked into my clinic with this history, and I tell her, actually, your best choice is to do IVF, she will look at me and say, no, this doctor is trying to make money out of me. So she actually wants to try and conceive naturally. And so we have to consider her options of how can she actually achieve a pregnancy naturally. So what are the options we have? So in these patients, let's look at what is the ASHRAE guideline. This is an ASHRAE guideline that came out in 2014 on the management of endometriosis. And they say that in women with moderate to severe endometriosis, there's no good control study comparing reproductive outcome after surgery and after expectant management. Two high-quality prospective cohort studies showed that crude spontaneous pregnancy rates of 57 to 69% moderate endometriosis and 52 to 68% severe endometriosis after laparoscopic surgery, which is much higher than a crude pregnancy rate of 33% in moderate and 0 after expectant management. These are the studies. These are 3 studies that was quoted. There's another study that came out more recently, and it's entitled Spontaneous Fertility After Expectant or Surgical Management in Patients with Rectovaginal Endometriosis in Women with or Without Ovarian Endometrioma, a retrospective analysis. So they actually took patients who have rectovaginal endometriosis, and then one group, they make them wait for a year to see whether they get pregnant on their own. Another group, they did surgery and then made them get pregnant. Another group is patients with rectovaginal endometriosis with ovarian endometrioma. One group, they made them wait for 1 year to see whether they conceive. Another group, they did surgery to see whether they can get pregnant. And this is what they concluded. They concluded that the crude and cumulative spontaneous pregnancy rate are lower in women treated with the use of expectant rather than surgical management. The presence of ovarian endometrioma decreases spontaneous pregnancy rate independent of the treatment modality adopted. So what they are saying, as what is said earlier, is that if the patient has an endometrioma, with or without rectovaginal endometriosis, and if you do surgery, she has a better chance of spontaneous pregnancy than if you let her try to conceive on her own. So if the patient has endometrioma and does not want to do IVF, then we got no choice but to do surgery. The question is, which surgery? Would you want to do laparoscopy or would you want to do laparotomy? Is there any evidence to say that laparoscopy is better than laparotomy? Again, let me quote this paper which came out in 2017. It's called Recommendations for Surgical Treatment of Endometriosis Part 1 for Ovarian Endometrioma. And here they say that laparotomy is rarely indicated for benign ovarian endometriomas regardless of diameter of the cyst or the associated adhesions. If the procedure is too difficult to perform by laparoscopy, it is better to stop the procedure after the drainage of the endometrioma, prescribe generation analog for 3 months, and then reoperate 3 to 6 months later. Alternatively, the woman may be referred to a center with a necessary surgical expertise. So, in this day and age, we shouldn't be doing laparotomy. We should be doing laparoscopy for these patients, and that should be the gold standard for patients with endometrioma. Next, let's go look at the patients whom we decide to do laparoscopic surgery. What kind of surgery are we going to do? The first is only remove cyst and leave all the other disease behind. This is perhaps done by many doctors. The second group will be doing remove the cyst and leave some and take out some of the visible disease, other visible disease. And the third groups are the more aggressive surgeons who will remove the cyst and excise all the visible disease and remove all the deep infiltrating endometriosis. Is there any evidence which is the best of these three? Many fertility specialists who are probably not very good laparoscopic surgeons will just do this or maybe a little bit of this. And they say that that is enough for the patient to get pregnant. Is there any evidence to say that this should be the one we should be doing? Now let's look at the available evidence. Now, firstly, let's look at cystectomy. In all three groups, as I showed earlier, we need to remove the cyst wall. But we also have other options. This paper that I showed earlier came out in 2017. These are the recommendations, and they say that there are actually 4 options we have for endometrioma. The first is a cystectomy. The second is ablation or laser of the plasma energy of the endometrioma. The third is to do electrocoagulation. And the last is combined technique. When we say combined technique, we actually remove, say, 80 to 90% of the cyst wall. And then at the hilum where there is most blood supply, we ablate. We just burn, electrocoagulate, or laser that area. So the commonest surgery that is performed is actually cystectomy, but this is probably one of the most dangerous surgery. We have to do it very carefully. And here, this is how they suggested that we should do the cystectomy. I'm going to go through this because this is very important. We need to do the cystectomy properly. Number 1, after mobilization of the ovary and drainage of the cyst, make an incision to reveal the cleavage plane. This may be either on the edge of the cyst opening or at the central incision, which divides the cyst into 2 halves. With both approaches, the incision should be away from the blood vessels in the hilum or mesoovarium. The use of cold cut at the edge of the cyst opening may assist in identifying the cleavage plane. Number 2, to aid dissection and identification of the cyst wall, saline or diluted synthetic vasopressin solution may be injected into the capsule. The diluted synthetic vasopressin injection has the additional advantage of reduced bleeding during cyst removal. Synthetic vasopressin is not available in all countries, although this it's rare. You have some complications such as vascular complications, such as bradycardia and hypertension. In some cases, the cleavage plane may not easily be identified after the ovarian incision. In such cases, it may be better to take a small part of the cyst wall for histologic diagnosis and then use ablation method rather than risking damage of the ovary from persistent attempt to perform cyst. We know that if the cyst is small, don't try to peel it out. If it is difficult, just ablate it. Once the cleavage plane is identified, use gentle traction and counter traction with the appropriate instrument to dissect the cyst capsule from the ovarian parenchyma. Traction and counter traction may be effective during the initial part of the dissection. Avoid using excessive force to separate the highly adherent cyst from the ovary, as this will likely cause tearing of ovarian tissue, excessive bleeding, plus need for coagulation or diatemy, and thus further damage normal ovarian tissue. Careful identification of the cleavage plane and precise spot bipolar coagulation is a key to achieve hemostasis, to prevent unnecessary damage to healthy tissue, and to avoid blind or excessive diatemy. Ensure final hemostasis after complete removal of the cyst capsule. Bipolar coagulation, suturing of the intra-ovarian hemostatic sealant agents may also be used for this purpose. It is important to avoid damaging the major blood supply at the hilum coming in from the ovarian and infundibulopelvic ligament at this stage. It's very, very important. Don't coagulate the hilum too much. After removal of the large endometrioma, it will be necessary to reconstruct the ovary and achieve hemostasis with monofilament sutures. For small endometrioma, suturing is often not required, as the ovarian opening usually approximates spontaneously. If suture is used, it should be ideally placed inside the ovary, as the exposed suture may be prone to adhesions. Then small cyst wall can be divided and retrieved directly through the port. Large cysts can be removed in a specimen bag. So this is how a cystectomy to be done. I went through this thoroughly. Actually, I could have shown you a video, but this is actually what the recommendation is, and this is what we should be doing. So next, let's look at the options. I showed you all that we have to remove the cyst, but is there any evidence that doing aggressive surgery to remove all the visible endometriosis actually benefit an infertile patient to get pregnant? So the question asked is, does aggressive surgery improve pregnancy outcome? Now, here is a study. The study is on laparoscopic treatment of bowel endometriosis in infertile women, and the conclusion is that the presence of bowel infiltration by endometriosis seems to be negatively influence the reproductive outcome in women with endometriosis-associated infertility. The complete removal of endometriosis with bowel segment resection seems to offer better results in terms of post-operative infertility. Another paper entitled Colorectal Endometriosis Associated with Infertility, Should Surgery Precede ART? Here it says that first-line surgery may be a good option for women with colorectal endometriosis associated infertility. So let's come back to this case scenario. You have this lady, 31-year-old lady, married for 1 year with endometriomas bilaterally. Is it correct to just remove the cyst and leave all the other disease behind, or just remove the cyst with visible disease, or try to make your best to excise all the disease and remove all the deep infiltrating endometriosis? We don't have randomized control trial to say that this is the right way to go, but I believe this should be the way we should be doing the surgery. And without any, side effects, any what you call as involvement of the bowel. So if possible, do the best surgery possible, and that will prevent recurrence and also most probably give you a better spontaneous pregnancy rate. Now let's look at recurrent endometrioma. This is another paper that came out in the year 2020, Recommendations for Surgical Treatment for Endometriosis Part 2 for Deep Endometriosis. And in this paper, they recommended that IVF could be proposed as a first step in patients who have been operated previously, who have low ovarian reserve, and or when there is male factor infertility. Oocyte freezing may also be needed to discuss with an option in cases of coexisting ovarian endometrioma. So if the patient has recurrent endometrioma, it is more important to tell the patient that she will be better off doing IVF than to do surgery. So what about this group of patients who have already decided to do IVF? Should we do cystectomy first before we go on to IVF? This is a very interesting debate on the ovarian endometrioma and infertility. Should we do IVF first, or should we do first, laparoscopic surgery first? And in one of the discussion by this doctor called Velasco, he said that 15 years ago, we showed in a retrospective study that removing the endometrioma in women undergoing IVF did not improve cycle outcome. Conversely, operated patients required higher doses of gonadotropin, had a lower production of E2 during ovarian stimulation, were exposed to surgical risk of laparoscopy, as well as cost and prolonged their time to pregnancy. Since then, more evidence has appeared along the same line of thinking. And even though mere presence of endometriosis by itself may inflict damage on the ovarian reserve per se, especially in cases of bilateral endometrioma, today most would agree that the main damage is post-surgical. Anti-Mullerian hormone concentrations will fall by 40%, and the operated ovary will show a lower antral follicle count, will produce a lower number of mature follicles, and will have higher risk of having no oocytes collected when compared with contralateral non-operated ovary. So another speaker said that ART should be carried out as the first intention in the following situations: decreased ovarian reserve, associated infertility, male factor or tubal factor, ovarian endometrioma recurrence, previous history of surgery for endometriosis. The indications for surgery are a rare situation where there's doubt that there may be cancer and the existence of intensive pelvic pain associated with infertility, which may be the main indication. So this is my last slide. What is an ideal world? In an ideal world, there should be complete investigation of a patient by a specialist in ultrasound and MRI for endometriosis, so that the extent of the disease is known before the surgery. This does not happen in Malaysia or in most part of the world. The second is the patient with endometrioma should be counseled about the benefits of moving straight to IVF. As I showed earlier, when the patient has an endometrioma, she is better off going straight to IVF than to do a laparoscopic surgery for the endometriosis, because surgery, if it's done, it should be done. If surgery is done for patients who want to conceive naturally. So of course there are patients who say that no, I don't want to move straight to IVF. I want to try and conceive on my own. Then you will consider surgery. And if you want to do surgery, then we need to classify surgeons into different technical skills. The first is a beginner who probably will be able to just do the easiest cases, that's minimal and mild endometriosis. And the second is the advanced group. These are patients, doctors who have spent time learning the skills to do difficult surgeries, and they are done by surgeons with the best skills with multidisciplinary approach, such as urologists and colorectal surgeons. Unfortunately, most people are in this group, this intermediate group. They are more than a beginner, but does not have the skill to go into advanced. And I think these people either have to improve themselves so that they become expert surgeons, or refer the patients to an expert surgeon so that an expert surgeon could do the best possible surgery for the patient, so that she will have a best chance of conceiving naturally and not going into IVF, and also with less complications. That's my talk. Thank you. We have a lot of time for questions. Back to you.
Thank you, Dr. Silva, for such an interesting talk. So now we are in our Q&A sessions. So we are waiting for the questions to pop in. So there's one question here. In patient with endometriosis, would you prefer a fresh embryo transfer or a frozen embryo transfer? Which has the more success rate?
I am not sure whether there is any evidence-based medicine studies to show which is better. I actually personally look at all the available evidence from that patient, whether she is suitable for fresh embryo transfer or not. Now, we are all now doing antagonist cycle, and from my personal experience, it is very difficult to keep the progesterone level down for a fresh embryo transfer. So if the progesterone level is down and the estrogen is not so high, then we can do a fresh embryo transfer. But unfortunately, that is not a common phenomenon. So in fact, in my practice, a large percentage of patients actually do frozen embryo transfer. I don't think, I'm not sure whether a frozen embryo transfer will give a better pregnancy rate than a fresh embryo transfer, but more and more evidence is coming out that FET is probably the way to go. And a lot of people are doing what you call as freeze-all and doing a frozen embryo transfer.
All right, thank you, Dr. Silva, for your input. There's another question here. Is there any benefit of using tests like CA125 or AMH to improve pregnancy rates?
Now, I think CA125 is of no point. I don't do CA125. I mean, it will not kind of help me in infertility patient or in monitoring the patient. I will do an AMH in all my patients. My personal preferences before I do a laparoscopic surgery, so as to give me a guideline as to what the AMH is before the patient goes to the theatre. This is especially so if it is a recurrent endometrioma. Now, you don't want the patient to blame you for decreasing her potential, so you must tell her that now, before the surgery, your AMH is whatever figure. You're actually on a low stage. Now, if I do surgery, it is going to go lower. That's what the evidence say. You decide. You may choose. If it's too low, you may choose to do IVF. At least I do an IVF. I collect some eggs. I've got an embryo available for you, and then proceed on to the surgery. So it is not an indicator of success in pregnancy rate. It's an indicator to tell your patient that your potential is not good, or it's actually low. So you might want to consider IVF before doing laparoscopic surgery. I would prefer to do that. The reason is because I don't want the patient to blame me for causing her infertility after the surgery, even though I try to do the best possible surgery.
All right, thank you. There's a few more questions that's pouring in. So one of it is, post-surgery, do you delay fertility treatment? And if so, for how long?
Okay, this is always the debate as to whether to give them some GnRH analog after the surgery. My policy has been not to give the GnRH analog. The reason is because I think I do a good surgery. I do 95% excision of endometriosis, and so the patient's best chance to conceive is the next month after the surgery. But recently I gave a talk on GnRH analog and the use of GnRH analog in a gynecological patient, and there has been some studies that say that if you give GnRH analog for 2 or 3 months after the surgery, they actually get better pregnancy rates spontaneously or by IVF. So my suggestion to most doctors who actually are doing incomplete surgery is to give some GnRH analog. I think most of them do. They give 3 to 6 months and then proceed on to help the patient. But remember that you're delaying the patient's chances of pregnancy. You can do 3 months, maybe that's enough. Even if you give say a leuprolide acetate 11.25 3 months, it actually works for 4 months, maybe even 5 months, and the patient will not be conceiving for that time, and then the patients can try to get pregnant. So it is individualized. My preference is not to give, but the doctor have to decide whether to give that or not. Okay.
All right, thank you. There's another question here. Do you use Visane in infertile patients?
Now, I use a lot of Visane or Dynogest in patients who are single and who does not want to get pregnant. That's my first line management. That means if I do a surgery on these patients, I will tell them you must take something, if not Visane, at least oral contraceptive pills, until you get married and you want to get pregnant. But in a pregnant lady, I do not give. I don't know whether it is worthwhile or not. Say, remember I showed in this paper, in these studies, that if you have endometrioma and you just tell the patient, okay, go and try and get pregnant for 1 year and come back in 1 year's time. If you don't want to do surgery, whether you can give Visane during the 1 year, but if you give Visane, she's not going to get pregnant. So Visane is, although it is not a contraceptive, it is not going to help the patient to get pregnant because it's a progestogen. So it defeats the purpose of giving Visane to a patient who wants to get pregnant. So you either move the patient to IVF or you do surgery. You have no other choice.
All right. So there's another question. There's quite a number of questions pouring in. So one of them is, will you have problems with forming oocyte pickup in bilateral endometrioma?
Okay, this is a good question, but and it is a relevant question. So I think you have to look at the endometrioma and see whether it is going to be a problem or not. Sometimes I will tell the patient, okay, I'm not sure. Everything boils down to money. If you are prepared to give, say, 3,000 to 4,000 ringgit for 3 or 4 days or 5 days of FSH injection and see where the follicles are, I can be able to tell you that, okay, we can proceed to do a IVF. Sometimes by looking at the endometrioma, I will never know where the follicles are going to come, going to develop. It may be behind the endometrioma, or it may be difficult to get to it. So that is basically the issue. So if the patient, okay, I'm willing to take the risk of doing the IVF with the endometrioma, then you go ahead. You can do the aspiration of the cyst during the oocyte collection, which can be very difficult with a 17 gauge and a thick endometrioma. You may not be able to, but you can just push through and get to the follicle and collect the follicle. So this is usually an excuse to do the surgery, but it is not necessarily the reason to do the surgery. That's what I'm trying to prove. Okay.
Right. Okay, thank you. Is there any role of suppressing CA125 prior to embryo transfer to improve pregnancy rates?
Now, I don't know about this. Some people will say that this patient has endometriosis and she has, say, high CA125, whatever, and you have collected the embryos and you have frozen the embryos. Is there a role of either giving Visane or giving GnRH for 2 to 3 months to suppress the environment and then do an embryo transfer to improve pregnancies? I have not done a research on it to see whether there have been any studies to supplement this hypothesis, but it seems very logical. In my mind, it seems very logical. If you have not done surgery for endometriosis and you're not going to do surgery for endometriosis, and you have done an IVF and collected the follicles and frozen the embryos, then giving the patient some kind of treatment for 2 or 3 months, because you're not going to transfer the embryo straight away. While the patient is waiting, you to give them some GnRH and then do the embryo transfer sounds logical, but I don't have evidence-based medicine to support it. It may be there, but I haven't looked for it.
All right, there's another last question here. What about single women with endometriosis? How do we approach in managing her? I guess this is trying to ask whether are we going to do oocyte freezing or how?
Okay. Up to now, I am not doing oocyte freezing, but after preparing this lecture, there's some option that I can give the patient. You see, if the patient has an endometrioma and she's single, she's 30 years old and she's got bilateral endometrioma and she's single, what are the options you have? You can do surgery to do the cystectomy, and then you can give her Visan or GnRH or whatever to suppress until she gets married and get pregnant. This is one choice. The second choice is actually to give them Visan or oral contraceptive to suppress the disease, wait for her to get married, and then ask her to get pregnant on her own. If it doesn't, then decide on either IVF or do laparoscopic surgery. Of course, the third option now is whether you want to do oocyte recovery and freezing the oocyte. I think this is a very important thing that we need to think about. This has been suggested by Ashray actually to do oocyte retrieval and freezing, but I don't know whether our single women who are probably Virgo intacta will want to do this or not. So it's something to consider, and I think something that we need to discuss with our patient, our educated patient. This is another option for them. Okay?
All right, thank you. There's one last question that just came in. In patient with endometrioma and no fertility desire, can Mirena help to reduce the endometrioma size?
I don't know whether it will reduce the endometrioma size, but it definitely will help her symptoms in terms of pain. So now the issue about endometrioma is, why are we operating on these endometriomas? I mean, if the patient doesn't want to get pregnant, it's basically because of pain. So we can use any other method to help the patient instead of going and doing the surgery. We can put in Mirena, or we can give them Visan, or we can give GnRH for a while and then give Visan. Anything to reduce the pain. We can try. If it doesn't work, then we have to move on to surgery to clear up the disease. So it all will depend on not the endometrioma, but in this case will be the deep infiltrative endometriosis, how much DIE she has and how much pain she has. So here we are looking at relieving pain. Of course, we will have to try all the different types of non-surgical method first. You can try Mirena, you can try Visan. If it works, fine, just leave her alone. If it doesn't, then we have to go in and do the surgery. Okay, anything else? I see Ashley frozen. Can you all hear me?
All right, thank you very much for yeah, can you hear me?
Yes, I can hear you. I can hear you.
Yeah, all right. So thank you very much for answering all the questions. Very informative talk. Yeah, so we shall end our session here. Thank you for being with us, Dr. Silva. So we shall have a break till 11 a.m. and then we will continue to our next sections later on. So thank you, Dr. Silva. Have a nice day.
Thank you, everyone, and thank you again to OGSN for giving me the opportunity to share my thoughts. Bye.
Bye.